So I'm happy to introduce our first speaker for this morning. Dr. Charlotta Lindvall is an associate physician at Brigham and Women's Hospital, a physician in psychosocial oncology and palliative care at Dana-Farber Cancer Institute, and an assistant professor in medicine at Harvard Medical School. She received her MD and PhD in medical genetics from Karolinska Institute in Stockholm, Sweden, and continued with postdoc training in cancer genetics in Michigan. She also completed a residency in internal medicine at Michigan State University, a clinical fellowship in palliative care at Mass Gen, Brigham and Williams, and Dana-Farber Cancer Institute, and was a research fellow in general medicine at MGH. Her principal interest is in research at the intersection of big data and palliative medicine. She develops cutting-edge natural language processing methods to identify the patient experience in electronic health records, which have played an integral part in multiple clinical trials and a national quality assessment study at the VA. She is currently funded as a PI on several grants in addition to working as a co-investigator on NIH-funded projects. She is dedicated to teaching collaborative data science in medicine and will be speaking to us today on the topic of opportunities for AI in palliative care. Please join me in welcoming Dr. Lindvall.
Well, thank you very much for inviting me to present. Very excited to be here today. So I'm going to talk about how my interest in math and genomic data turned into interest in capturing the patient experience and communication outcomes in palliative care. So we know so I work at a very large cancer institute, and I think it's so important to really think about cancer care as the cure and care, how they go hand in hand. We're all hoping for a cure in the future, but even with a very good chance of a cure, patients with cancer have their experience of going through cancer treatments and living with cancer. And that's where I hope to use my methodologies to really capture the patient experience, symptoms from cancer and from cancer treatments, and also communication outcomes to really improve that experience here and now as patients go through their treatment. So what's challenging about capturing those outcomes is that they're usually not structured data. Like, you know, if we want to look at blood pressure or kidney function, it's easy to find an electronic health record because it's structured, it's a number. But when it comes to tracking symptoms, they're often documented in free text and clinical notes. And so they're unstructured and they just get buried in the patient's health record. And also communication outcomes, including discussing goals of care and patient's priorities, or even family distress, caregiver distress and caregiver social support are often in the clinical notes and difficult to study because they're not, they tend to get buried in the electronic health record. And so I'm really like, the focus of my work is like turning that unstructured data into more structured data so that it can be studied. So first I will talk about cancer symptoms. It's a pillar of palliative care. We are experts in treating symptoms, and cancer patients, cancer and its treatment are associated with frequent symptoms and treatment toxicities. And we know that uncontrolled symptoms are associated with discontinuation, early discontinuation of chemotherapy. And we also know that tracking patient symptoms is associated with improved clinical outcomes. The way we tend to track symptoms, and I would be curious to hear what you do at the University of Miami, at Dana-Farber, we really push patients to report their own symptoms through patient-reported platforms. So patients get surveys sent to their patient portal, and they are asked to fill out a survey on their phone or an iPad and report their own symptoms. We have spent tremendous amount of effort implementing the system, and we still have a very low response rate. Less than 50% of patients actually report their own symptoms. It's just we have limited, we have patients are, they go through illness and they are asked to do many things. So asking them to fill out another survey sometimes is just not feasible. And And so it's important to think about other types of data that's already available in the electronic health record that we can use not to replace patient-reported symptoms, but augment patient-reported symptoms. And so PRO, that's the patient-reported symptoms. My lab is studying electronic health record data, and we're also studying symptom documentation that clinicians put in their clinical notes that wouldn't need patients to do anything extra. And also we're studying audio recordings where we collect audio recordings from patient oncologist encounters and just capture symptoms that way. So why is electronic health record a good source of symptom tracking? So some people will say, well, you know, oncologists, maybe they don't, maybe they tend to document more serious toxicities like shortness of breath or chest pain, and maybe less depression, anxiety, fatigue. But what's powerful with these like advanced computation methods is that we can take all the clinical notes. So we take all the clinical notes. We take the notes from the infusion nurses, from the social workers, from the chaplains. So we process, because we can process thousands and thousands of clinical notes. We don't only need to focus on the oncologist note. We analyze notes from all the members of the clinical team, and we find that there is a ton of symptoms documented, and especially by the nurses. By the infusion nurses tend to document a lot of patient symptoms. And then, you know, we also, of course, have to look at, and it's very different to say patient has pain versus patient does not have pain. So we have to identify the negation, you know, is symptoms endorsed or negated. And so we are doing this at scale at Farber. And we have a model called that we call MLSIM for machine learning symptom tracking. And we have shown that when we compare, so we have clinical notes that were manually annotated, so they were labeled by clinicians, and that's the human ground truth, where clinicians, nurses went through and word by word annotated if symptom was documented. And then we used our machine prediction, and we had very high performance of our automated symptom tracking model that is based on machine learning. And this model really allows us to track symptoms at the encounter level. So we take all the documentation that patients accrue when they come to Dana-Farber for a visit, when they see the different members of the care team, and all those different members document in the EHR. And we basically compile everything we find, and then we get a symptom profile for the patient. And based on that profile, I should also say that we have also showed that what we find in the documentation in the EHR very much match what we find when patients report their own symptoms using their phone or an iPad. So that gave some face validity too to using this automated symptom tracking method. Again, it's not replacing patient-reported symptoms, but it's augmenting, it's helping with missing data where we don't know, where we are concerned that maybe we're missing some symptoms or we're not proactively treating symptoms. So what we have done after we built the model is we have set up a framework to use symptom tracking as prediction variables in models that predict unplanned acute care visits, so ED visits and hospitalizations. And I think this is important to use symptoms in these models because we know that cancer patients, the most common reason cancer patients patients with advanced cancer get admitted to the hospital is because of uncontrolled symptoms. And so we really want to be proactive if we know that patients have more documentation of pain or other symptom, that we can be more proactive, because often in cancer care, we are reactive. We start treating symptoms once the patient is in the ED or in the hospital. And as a palliative care clinician, I often feel, had I known about this a few days before the patient went to the hospital, maybe we could have done something in the outpatient clinic. So that's the whole idea of having this linked into EPIC. I think also it's really important to build prediction models that are based on actionable items. So I have been very concerned about many of the models that build to predict mortality, because like mortality, like what do we do with that? We know that some patients with advanced cancer, we can predict that they have a poor prognosis and have a high risk of dying in the next 6 months or next year. But what do we do with that? It's like, what action do we actually, yes, we can definitely have a goals of care conversation, but with symptom, I feel like it's more patient-centered. We can treat symptoms, we can improve the experience of living with advanced cancer here and now. And so that's also, I've been writing about this, like these mortality prediction models that are quite common, and also that EPIC have implemented in the EHR. I feel like symptoms is something that we can be proactive and treat and improve the experience for patients living with serious illness. Another topic that my lab is working on is communication around goals of care. So again, I think maybe mortality prediction could be used in combination with there is no documentation of our goals of care conversation. I wouldn't use mortality prediction in isolation, but if there has not been any documented conversation about goals of care, maybe we could trigger a goals of care nudge, goals of care conversation. Often we talk about advanced care planning, which is like the concept where just to name the definition for you, is a process that supports adults at any age or stage of health in understanding and sharing their personal values, life goals, and preferences regarding future medical care. And again, these conversations, they tend to be, when they take place, they tend to be documented in the clinical notes. At Dana-Farber and many other healthcare systems, there are places, structured modules in EPIC where you can document the conversation, and it's easier to find. But again, it's very difficult to implement changes in workflows for clinicians. So we capture these conversations and documentation using advanced computational methods like natural language processing. So we find keywords and phrases that indicate that a goals of care conversation did take place, and we can display that to the clinical team, to the patient's multidisciplinary care team. We use this software that, and you're welcome to go to this website. It's a free software that was built in my lab. We have built many keyword libraries for words that are highly associated with documentation of goals of care, of family meeting, of having discussions regarding code status. And this software and the keyword libraries, there are all our publications and also some videos in how we use the software. We're working in multiple clinical trials where we use this approach. And here are just two papers. The first one, we analyzed 35,000 patients, the medical record of 35,000 patients in an entire healthcare system, Northwell in New York. We looked at documentation of goals of care in their primary care clinics for older adults. And it would absolutely be impossible to not use computational methods to analyze such large data sets, because if you think 35,000 patients, they may have hundreds of clinical notes and going through that is just like absolutely impossible. So doing this with natural language processing and softwares like clinical regex makes it feasible. At Dana-Farber, we also have set up a pay for performance program where we actually report documentation of goals of care conversations directly to our payers and get and so we measure quality by using these like free text documentation of these conversations. And in addition, we also support our oncologists by training them in communication skills and nudging when to have a conversation and free up some time for them to make the appointment longer so they can actually have the conversation with the patients. I'm going to just share some limitations and future work. One major limitation of this work using electronic health record is that it's always processed by a clinician. You know, the clinician is documenting, and so it's what the clinician decides to document. It's also not documented in real time. There are delays in documentation. And it's how the clinician interpreted the clinical encounter. So what we're doing now, and I will not have time to go through this except to show our pilot, is we really want to capture conversations in real time. So we want to do automatic speech recognition, and that is like capturing the conversation as it happens, and then doing converting that that conversation into outcome data. So we have completed a pilot where we use telehealth visits because, you know, I'm presenting by Zoom. Zoom has very good audio, so it's easy to collect audio from a Zoom telehealth visit. And it's also the method for converting what is said to text is also quite advanced. And then once we convert the audio to text, we can track symptoms and we can track goals of care conversation directly from the visit. The challenge with this is that physicians have been less enthusiastic about having their clinic visit recorded. Patients have been very, very open to having this done. I think that once we can help clinicians with the documentation, maybe automate some of the documentation to lower the burden of clinicians having to type their notes. I think clinicians, that is the way, the buy-in I think we can get from clinicians, that they don't feel like they're just being, you know, like someone is like listening into their conversations, but actually having audio recording, having the visits audio recorded would also really reduce the amount of manual documentation. Then we get way more buy-in from clinicians because everyone knows that it's extremely time-consuming to do that manual documentation, and some of that can be automated. And I'm very, very excited about this work because that's where we can, I feel like, get more ground truth, because it's the conversation and not only what ends up being documented in the electronic health record. And it's also real time, so there is no delay in doing this. And so I will end there by saying that that this work we are scaling at Dana-Farber, and there's also a lot of industry partners who are, you know, even Epic is looking into automating some of this. But I'm hoping that through this capturing data directly from conversations, that we can also capture more of the patient-centered data like symptoms, caregiver distress, and goals of care conversations, patient's goals and values. So with that, I thank you very much, and I will give you my team here, to my team and my funders. I'm happy to take any questions.
Thank you, Dr. Lindvall, for that very interesting presentation and joining us all the way from Boston today for the first part of our grand rounds. Perhaps I can begin by asking you a question, which I'm sorry in a way, because I don't think you're going to have an answer, but I'd love to hear your thoughts about it. And that is, oftentimes many of the interactions between a physician and their patient is not necessarily verbal. And there's lots of nonverbal cues that are sometimes felt by the doctor when I'm sitting in a room with the patient. And it may not be the actual words that they say, but the way they say the words, their facial grimaces and so forth. Is there a way that AI is going to somehow capture facial recognition and changes like that? Or is there anybody working in that regard?
Yes. I mean, I think that's a little frightening. Like, are we not going to like be able to, in a way, like hide sometimes how we feel? There is definitely work to do that. I think it's an amazing opportunity for like training and feedback, but there is a concern. I think, like, even on the Zoom call, that tools in the future could kind of monitor how I feel right now, or like there's a lot of work in that space. Absolutely, both with like the intonation and how we speak, and also with body language. So that's definitely coming, and it's just like going from one layer, more and more complex layers, right? And then you can imagine you can combine what's being said and how it's said, and also the body language.
But indeed, that's life, right? I mean, that's all the time. We as human beings interact with each other, not just based on what we hear, but on what we see as well. And yeah, this is definitely a slippery slope, but all of AI potentially is that same slippery slope. I'll open the floor up to any other questions. Thank you for that comment, though. Any other questions anyone has? They want to unmute themselves?
If I might, Dr. Weiss.
Dr. Goodman.
Thank you very much. In fact, Dr. Lindvall, thank you very much. The paper you cited is actually something of a classic in linking ethics and prognostic scoring systems. In the paper, you talk about the importance of how should we say, incorporating patients and caregivers in the use of these tools. What do you, from your experience, what do you think patients make of all of it? And are you comfortable with our colleagues using them without more education themselves?
Oh, I think that is just an excellent question. It's I think we absolutely need to involve patients and the caregivers in deciding what models we should use, and to make sure that we don't decide. I mean, we all probably think ED visit and hospitalization is important, but there are so many other, like when it comes to like mortality prediction or predicting other outcomes. Maybe patients, like what I hear from patients is that, actually having their symptoms treated is very important, and tracking, like finding ways like to track for clinicians to understand that extreme fatigue, it's like something they want to talk about, even though there's not like a great pharmacological treatment of cancer-related fatigue. So I think and I think that patient and families should be key stakeholders. And I'm concerned, I don't know if you use Epic, but Epic is putting out some models available to all Epic users that it's not clear sometimes how much patient and family involvement there has been in deciding what they would focus on. And also the second point, we absolutely clinicians need to know how to use the model and what the limitations of the models are, if before using, like there are many limitations, like where So at my healthcare system, I've seen one specific model from EPIC called the deterioration index. It's meant to track patients who may end up in the ICU and empower nurses, because nurses may feel like they keep telling this patient's getting sicker, this patient is getting sicker, and this model is supposed to like empower patients to really say the data is showing that patient is getting sicker. That's how that model is supposed to be used. But then other people have used it to kind of track that the patient has a poor prognosis during their admission. That's not the intended use. And so like once you switch the use, it makes me worried, because that's not how the model was even developed. But maybe people say, oh, this is very helpful to identify the sickest patients in the hospital. A lot of work needs to be done there. And I actually was very excited to write the perspective in Science in just July about this topic. So together with an ethicist. Yeah.
Thank you very much. We welcome you back to Miami anytime, and come for a personal visit when
that would
possible.
be wonderful.
And we thank Dr. Soares and his division of geriatrics and palliative care to sponsor your presence today. Dr. Danicki, can you please introduce our next speaker?
Yes, absolutely. So next we have Dr. Candice Sternberg. She is an assistant professor here at the University of Miami in the Division of Infectious Diseases. She completed her internal medicine training at the University of Florida, Jacksonville, and completed her fellowship in infectious diseases at the University of Miami, Jackson Memorial. She is a Haitian American early stage investigator with a focus on HIV prevention and treatment in the Haitian community in Miami. She is also a recipient of pilots and supplements through the Centers for AIDS Research and Center for HIV and Research in Mental Health through the University of Miami. She most recently received the Miami Clinical and Translational Science Institute K-12 Award for her work looking at PrEP delivery in the Haitian community in Miami. She will be speaking today on the topic of biomedical prevention amongst people of Haitian descent. Please welcome in joining Dr. Candice Sternberg.
Good afternoon, everyone. Thank you so much for joining. Today, I have the pleasure of talking to you about biomedical prevention among people of Haitian descent. So today, specifically, I'll be talking about biomedical prevention for HIV. So why is that important? It's important because Miami-Dade County is an epicenter for new HIV diagnoses, and these diagnoses primarily occur in racial and ethnic minorities. People of Haitian descent, meaning people born in Haiti and their descendants, make up approximately 8.2% of the Miami-Dade population. And what we've learned from the Florida Department of Health is that Haitian-born people also account for 13% of those living with HIV. People of Haitian descent also, particularly people that are Haitian-born, suffer from the highest rate of HIV-related mortality among immigrants at 14.2%, as compared to, for instance, people coming from, let's say, Venezuela or Brazil. And so this is a staggering statistic that we need to address. So how are we addressing this? We're addressing this through HIV prevention. We know through a number of studies now that U equals U. And so what that means is that undetectable equals untransmissible. So if a person living with HIV has an undetectable HIV viral load, then he or she or they are unable to transmit HIV to their sexual partners. So our goal really is to be able to ensure that the members of the Haitian community who are living with HIV are undetectable. And so what we've done is we've completed a study called Vive Bien, where we evaluated telehealth to improve HIV care among people of Haitian descent. There are multiple ways to prevent HIV: abstinence, condoms, pre-exposure prophylaxis, which are medications to prevent HIV prior to exposure. And then we also have post-exposure prophylaxis, which are the medications to prevent HIV after exposure. There are both behavioral as well as biomedical prevention interventions, but thus far, our behavioral interventions have not been as effective as we would like. So specifically focusing on pre-exposure prophylaxis, we know that pre-exposure prophylaxis is highly effective for HIV prevention, but there are unfortunately racial and geographic disparities in its use. In all US regions in 2022, Black individuals had a higher unmet need for PrEP than white individuals. So what are the indications for PrEP? Anal or vaginal sex in the past 6 months and any of the following. So a partner living with HIV and an unknown viral load, a bacterial STI in the past 6 months. And what I'm referring to here is particularly gonorrhea, chlamydia, or syphilis, and a history of inconsistent or no condom use with sexual partners, as well as sharing injection equipment if the person injects drugs. And so in addition, over half of the new HIV diagnoses occurred in the South, but only 38% of people receiving PrEP live here. So thinking specifically about the Haitian community, we went ahead and completed this study, the Bon Santé or Good Health Study, looking at knowledge, attitudes, practices, and preferences for PrEP delivery. And we made sure to partner with those in the community. So this was a qualitative study where we partnered with the Community Health and Empowerment Network and the Family Action Network movement. Both of these organizations are organizations that are well known in the Haitian community, and they promote health and wellness. We interviewed both Haitian and Haitian American adults in their preferred language using semi-structured interview guides. And we interviewed both community members and community stakeholders. Here, community stakeholders, everyone in the community is a stakeholder who's important and whose opinions we'd like to seek. But in particular here with the community stakeholders, these were people with leadership positions. And so we interviewed them, we recorded the interviews and transcribed the interviews, as well as translated as needed into English and coded and analyzed that data. Overall, we had 30 participants that were enrolled. For the community stakeholders, we had 15. They were aged 23 to 57. We had 8 women and 6 men. We had 1 person who preferred not to disclose. And then for our community members, we also had 15, aged 26 to 71, with 7 women and 8 men. And so we learned a lot from the study, but in particular, I really want to highlight a number of the elements that we really looked at to be able to further our research and be able to build off of. So one of the key things that we learned was that there was a large interest in HIV prevention. And so these are some of the quotes from the participants. I think they'll be happy to take it to avoid getting sick, you understand. I think it is good. It's like an internal condom, you know, it's like that extra layer of protection. I do think it's a miracle drug. Also, we learned that there was still a lot of stigma regarding HIV. It's rare to have a Haitian here that someone has HIV and still hang out with them. Stigma is a big issue in Haitians. There was also a lack of knowledge regarding PrEP. Many participants said, I don't know anything about it. And then we also learned that the church was a good source of information for many community members. Like I told you, get involved with the church community and leaders, all of the Haitian churches, so they will accept you and go talk and tell them. So we specifically use that information, the church as a source of information, to go on to our next study, which is the Bon Bagay or the Good Stuff study. And so the aims of this study are, the first aim or goal is to better understand the role that churches serving people of Haitian descent in Miami-Dade County and surrounding areas can play in delivering PrEP. And so with that first goal, we decided to do 3 focus groups using the semi-structured interview guides in both English as well as Haitian Creole. And we've completed those focus groups. And so I'm going to tell you a little bit more about what we've started to find in a few minutes. And then the second goal is to better understand preferences for PrEP among people of Haitian descent attending churches using surveys which allow for understanding preferences. And so at this point, we're really working to develop a discrete choice experiment to be able to get a better understanding of these preferences with 120 people in the community. And so here is our study team and pictures of us in all 3 of the focus groups that we've completed. And so we have a huge team with a research associate, community consultants, our community partners. We also have an advisory board, which helps us with our measures and also making sure that our measures are understandable for the members of the community. And then we have additional study team members and of course, study mentors, as I am an early stage investigator. And so what we've learned so far what we did so far with the Bombagai study, the very first focus group, we conducted it with 7 participants. And this one was done in Haitian Creole. And the focus group lasted 1 hour and 30 minutes. We had of our participants 4 women and 3 men, and 4 were Haitian born. The mean age was 57 and the ages ranged from 41 to 73, and about 86% had graduated from high school or had higher levels of education. As this was a church, 100% identified as Christian. For income, 5 reported an income of $50,000 or more, while 2 reported an income of $12,000 or less. Some of our preliminary results here. So far, we've been learning so much from the focus groups. And so I just wanted to highlight some of the different elements that came up thus far in our analysis. And so those had to do with religion, fear, education, stigma, HIV risk, as well as trust. So for religion, one participant said, if you're asking us from the church, is this a good thing to have? The first thing many Christians will think about is, well, the only way you would really want this is if you're doing something outside of what we're teaching. It's going to be a hard sell. So for this participant, PrEP would be a hard sell in the church community. Fear, specifically thinking about HIV testing. So you have heart palpitations when you're taking the test, regardless, right? Even if you think you're like good, but obtaining the results is also emotional and an anxious moment as well. Education, so how could we educate the community? With a group of Haitian professionals like nurses, pharmacists, all those people can come together to educate on the radio, television, in colleges. Once again, stigma came up. And this quote in particular had to do with stigma even among professionals. So the stigma still exists even among professionals, even sometimes at work. Let's say you're giving reports to someone with the patient and you say, you know, this person has high 5 and it's like, ooh, I don't want to take this. And so I think that was also like a very eye-opening comment, and comments like these have been seen in the other focus groups as well, making sure that we're thinking about stigma when we're working with patients living with HIV. HIV risk. If you're married, a husband and wife, I don't think you should have this problem. But if you're someone who is not married, well, even if you're not married, if you're a Christian, you should be waiting on God. You're waiting on God to send you your person, so you shouldn't, you know. So this person is really getting into the fact that maybe there shouldn't be necessarily HIV risk if you're a Christian. Trust. I know some churches have medical providers in the church. They usually have a medical team. I think if there's some sense of trust within people on that team, someone can confide in a member on there. And so that was more of a comment to get us more information regarding how we could get more of the people in the community to, for instance, discuss matters related to sexual health or HIV. So in summary, new HIV diagnoses are disproportionately affecting ethnic and racial minorities, and we know that people of Haitian descent are being affected, and that HIV prevention is truly very important in, helping with multiple things, including helping with decreasing the HIV related mortality. And so additional studies are really needed to develop strategies for HIV prevention in the Haitian community here in Miami. And so some of the future studies that we're working on are the Bon Santé Prolongée, or Good Stuff Continued study. And so this is a community engaged project to increase PrEP awareness and linkage in the Haitian community. And so we're planning to partner with 3 different organizations in the Haitian community to come up with a strategy to increase PrEP awareness and also increase linkage. That will be an implementation science-focused project where we'll use whatever strategy we learn to both pilot the PrEP awareness and linkage strategy, as well as to test it. We'll also be working on a new LAS study, or We're Here study. And this project will also partner with a community-based organization. So that would be the Community Health and Empowerment Network, as well as a clinic, Celeste Health Center in the Haitian community, in order to try to increase PrEP usage. The Community Health and Empowerment Network is already providing PrEP in the Haitian community. And so really learning strategies from them and trying to work with Celeste Health Center as well to increase PrEP usage at their facility. We'll also be working on another project called Bien-être, or Well-being. And this will be a project to focus specifically on HIV stigma, get a better understanding of HIV stigma, as well as long-acting PrEP in use in the Haitian community, as we know that long-acting PrEP is also available and may also be an option that may potentially help members of the community. And so here, I'd just like to say thank you to everyone, to our study participants, our research associate, our community consultants, our community partners, our advisory board, team members, and of course, our members and funders. Thank you so much.
Dr. Sternberg, thank you very much. You have been truly inspirational for me and for many of us on this call. To see your tenacity and what you've been able to accomplish during your time here has just been really heartwarming. And I'm so proud of everything that you've done by yourself, and the accolades that you received in Washington a couple of weeks ago when you presented this to a large group of individuals looking at health disparities. It was really wonderful. So congratulations for all of this and all your accomplishments, and we wish you continued success. Given the fact that the number of Haitian Americans and Haitian immigrants are actually exponentially increasing in the last several years due to what's happening in Haiti itself, this becomes really an important issue, not just for Miami, but for other cities in the United States. And I'm wondering whether or not you might have some insight as to whether or not this can be done in other cities, and how universal one could apply these things.
Yes, I do think that a lot of what we're learning can be applied to different areas. I think that it'll be important to partner with other researchers and other even community members in other areas of the US, as well as even Canada, where there are large numbers of Haitian people to be able to develop strategies. There may be some nuances and differences, but I think specifically partnering with community members as well as community stakeholders in the Haitian communities where they are will be helpful to develop strategies.
Anyone with other questions that they'd like to unmute themselves for? Well, I want to thank both our speakers today for an absolutely amazing Grand Rounds, and remind everybody to check in the chat for the link for the CME and MOC. And everybody be safe, and I look forward to seeing you next week.